My name is Mark Jeng. I'm one of the medical oncology fellows at Memorial Sloan Kettering Cancer Center. I'll be joining as faculty later this year. And yeah, that was presented. I'm going to be presenting this work at TTLC next week. And so the crux of the project really has to deal with this concept of zygosity status or gene zygosity, and I'll explain a little bit of what I mean by that, and its impact on these two genes, KEAP1 and STK11. These are two tumor suppressor genes that have been associated with resistance to immunotherapies in non-small cell lung cancer. And so when I talk about zygosity status, I'm referring to the relationship between a gene mutation and the allele status. So does it affect one allele, monoallelic, or is it impacting both alleles, biallelic? This is underappreciated partly because most of our next generation sequencing platforms actually do not report out the zygosity status of mutations that we find. But there's emerging work to suggest that this is actually critically important for some of the effects of these mutations. Now, we're focusing on these two mutations specifically. There's been a lot of work looking at both KEAP1 and STK11, showing that they are indeed associated with resistance immunotherapies. And there's been really compelling work out of MD Anderson recently to show that the addition of anti-CTLA4, so dual checkpoint blockade, can actually reverse this effect and maybe improve outcomes with patients with these mutations. And so our research study really wants to look at how does the zygosity status of this mutation impact that effect. And so here at MSK, we have a clinically validated cohort of over 1,800 patients. These are all metastatic or recurrent non-small cell lung cancer patients treated with immune checkpoint blockade that have undergone next generation sequencing with MSK Impact. That's our in-house NGS platform. This platform allows us to infer things like zygosity status. So we applied that to this cohort, and then we looked at outcomes like PFS, OS, response rates. And the big takeaway is that indeed, we find that zygosity status is really important here. So when we look at patients with biallelic inactivation of these two mutations, KEAP1 and or STK11, those treated with the dual checkpoint blockade had a better PFS compared to those treated with single immune checkpoint blockade. So that's important. But more importantly is when we look at patients with monoallelic inactivation, we no longer see that separation of the curves, suggesting that we only really see this rescue effect in patients with the biallelic inactivation of KEAP1 and or STK11. We did additional analysis showing that KEAP1 really is the stronger effect. So patients with KEAP1 biallelic inactivation, we see a bigger separation of the curves. We also see that overall survival, there's a big difference with biallelic inactivation of KEAP1 and response rates. We're starting to do multivariable analysis to look at other factors as well that might be playing a role. So things like PD-L1 status, we are finding to be significant. And we're also seeing that KRAS mutation status may also play a role here. So I guess the big takeaway is that, in fact, we do strongly believe that the zygosity status is underreported, but critically important for choosing patients and optimally choosing patients for the right types of therapies. So patients with these KEAP1, STK11 biallelic loss, we think may benefit the most from this dual checkpoint blockade regimen.